Welcome to Ultrasound at the Front Door. My name is Dr. Sarb Clare. I'm an acute medical consultant and Deputy Medical Director at Sandwell and West Birmingham NHS Trust. I'm the founder of Ultrasound at the Front Door, and I've been running this course over the past 10 years with an amazing faculty including emergency physicians, intensivists and respiratory physicians, as well as my acute medicine colleagues. During this pandemic, we think it's really important that we can offer teaching and training for those of you to learn this mandatory and really vital skill that is required. We're offering our course free for all of you to learn lung ultrasound as well as echo point of care ultrasound. Over the next hour or so, you'll be learning how to scan a chest and a heart, acquire skills to understand what does normal look like as well as abnormal. So those of you that know me, you know that I'm incredibly passionate about ultrasound. I've been doing point of care ultrasound over the past 16 years, and it is really a vital skill that all clinicians, not just in hospitals, but out there in the community, paramedics and so forth, really should learn to acquire. So acute medicine is all about us looking after patients within the first 72 hours, from the very sick patients, level 1, level 2 care, all the way out to admission avoidance. And in each group, from sending people home to patients who are really sick, you can use point of care of ultrasound to help you make decisions. So on the acute medical unit, we are scanning lungs, hearts, legs, and we're now even scanning eyes for papilledema. It can be used in all presentations. The beauty of ultrasound is things have really changed. So from the big machines that we traditionally see in the radiology departments, things have got smaller. So we have now smaller machines that are more portable, cheaper, to the point where now we have a scan which can incorporate all 3 probes and scan all different parts of the body. And this is the key thing. It's about portability, being able to take your diagnostics to the patient. And this is really key when patients are sick and they're unable to go to the various departments to get these skills. This is even more important out there in the community when it's inappropriate to bring patients out back into secondary care to get these tests. So why should you do this, and how is it going to help you? And this is my experience over the past 16 years. Without a doubt, it will help you save lives. In a cardiac arrest or peri-arrest situation, you can pick up the patient with an acute pulmonary embolism and thrombolyse them and save their life. It puts you on the right path. Many a times that you may be going down the wrong way, it excludes that diagnosis or it confirms it. Importantly for myself, I found that it really helps me decide whether this patient should be for intensive care. You know, is the systolic function normal or abnormal? What is the ceiling of care? We have seen that traditionally in med school we have been taught to use a stethoscope, and this is simply an extension of your clinical exam. Of course, it helps you carry out procedures as well as discharge patients with real confidence. For example, if a patient comes in dizzy, you hear a murmur, you can scan the chest that yes, they have got aortic stenosis, but it's not tight, so the patient is safe to go home. For me and the team around us, it really empowers you as a clinician. It's enabled me to do lots of things. I've set up an admission avoidance clinic. I've been able to go out to South Africa and do some great research where we take out scanning out into the communities. And it's really broadened our ability as a clinician. But more importantly, and the most important thing, is it improves the patient journey. It decreases the length of stay and the time to diagnosis. So we're doing this for our patients. POCUS has a massive growing momentum, and technology is changing and we need to keep up with it. As I said, the devices are getting smaller, getting better images. We're not asking for complex decisions or answers. It's a yes-no thing that we're going to ask. And it literally takes less than 5 minutes to scan. Incredibly cost effective for the NHS, and we need to give the right skills to the right people. So paramedics, GPs, people at the front door. There's lots of accreditation now that's coming through the system, and I'm really proud to say that the City Hospital within the West Midlands is a real beacon for ultrasound and POCUS. And we need to follow the US, where it incorporates POCUS as part of the curriculum as the part of the undergraduate curricula, and we need to do that within the UK. So our doctors are coming out with these skills ready to crack on. As I mentioned, various pathways of accreditation. I'm not going to go into detail, but there's parties from intensive care, acute medicine and the radiology teams have put all these together, and this is for focused point of care accreditation. Just very briefly, the Royal College of Radiologists have put a level 1 thoracic accreditation together. It's all about getting a mentor to sign you off, attend a course and get the various competencies. And it's really about competency and someone supervising you do these scans, and when they feel that you're ready, you can scan independently and report. FICE accreditation is focused intensive care echo, and again you attend a course and you're answering simple questions. You get a supervisor, you get a logbook and you get a sign off. So they're just a couple of examples of accreditation that you may want to get yourself involved in. This is something that one of my trainees, Dr. Chris Duncan, has put together, Ultrasound at the Front Door, a website, www.ultrasoundatthefrontdoor.com. Please come and visit it. It tells you about all the various routes of accreditation and also has a varied range of cases that we have seen on the acute medical unit, emergency department and intensive care. It has great sources of learning and education for you all. So you may ask me, where's the evidence for ultrasound? And if you look at this study that was done by Liechtenstein and his team, it is overwhelmingly telling you that ultrasound is superior than chest x-ray and auscultation in pleural effusion, pneumothorax and pulmonedema. And this has been repeated time and time over again. So the evidence is clear and it's accumulating as time is going on. This is something that he's put together. It's very busy and I'm not going to go through it, but it's something that he put together in somebody who has acute respiratory distress, a simple sort of algorithm. If you see A lines, you look for B lines and so forth, but I'm not going to go into this in detail today. But this is something that Liechtenstein and his team had put together in patients in respiratory distress. So which probes do you need to use? This is what we call the linear probe, or what we use for vascular access, and it is great for looking at the pleura and diagnosing pneumothorax. And the reason is that it's high frequency, so it looks at things at the surface. The curvilinear probe, which we traditionally use for abdominal and chest ultrasound, is low to medium frequency. It has high depth with large surface area. You can use it for echo, but it has limited images. But this is the probe that you tend to use for chest ultrasound. Okay, so over the next few minutes, we'll be going through how to scan a chest. In a patient that's fit and well, essentially, ideally we'd like them to sit up, and we will start anteriorly. So starting with a curvilinear probe, lots and lots of gel, and starting at the top of the chest, and this is what we call a lawnmower process, just as you scroll down. And what you find is that because you have a lot of gel, the scanner and probe can often move, so I often use my little finger to stabilise the scanning probe. And essentially we will pop the probe onto the chest and look at our images, and we can see the image that we want, which is essentially ribs and pleura. And what we will do is we will gradually move downwards, down towards the chest, again looking for what we call sliding, which I will talk to you about later as the presentation goes on. We will progress down further onto the chest and then move on into the axilla. Now remember, it is axilla where often pathology sits, such as consolidation and pulmonedema, because that is gravity. So you can see there, and what you want to see is that, can you see the diaphragm, is any fluid, and can you see the liver? And then as you scan, you will change your depth and your gains accordingly. And then you will continue to do this procedure on the other side in the same way. So just scrolling downwards. And the key thing with lung scanning, I found you do need to keep the probe very still as it comes down. If you want to look at the pleura in more detail, you can turn the probe longitudinally and you can see that you're able to look at the pleura in more detail. Once you've scanned anteriorly, next you need to scan posteriorly. And again, you're doing the lawnmower approach, just scanning from the top. Again, getting your images of the pleura and sliding, and then scanning all the way down, slowly, holding the probe as still as possible. The thing with lung ultrasound is you do need a lot of jelly. And as you move down, you want to again move down towards the axilla, looking for any pathology. And here you will be able to see either the spleen or the liver, depending on which side you're on. And then again, repeat on the other side, starting from the top and then scrolling all the way down, keeping the probe nice and steady. Lung ultrasound in itself is a very easy scan to learn, to apply. And I learnt this by myself really from a book, so it is doable. So this is a scan of a normal lung. It's really important that you appreciate what normal looks like, as then you will not appreciate what abnormal looks like. Now the thing about lung ultrasound is air and ultrasound does not match. Essentially, it has very little what we call acoustic impedance, and therefore we don't see much at all. And what you want to be able to see is what we call the pleural line, which is this white stripe here, and you want to be able to see it moving. And if it's moving, then essentially it's normal. The other thing that you want to also see is things called A-lines, which I'll talk to you in the next few slides. So this is the image that you want to see. So this is a normal lung, and what we can see first of all is rib and a shadow behind it, rib, shadow behind it. And this white stripe here is the pleura. It's very bright, it's thin. And what you see beneath it is some bright stripes as well, and they're called A-lines. Everything else is normal lungs. It's essentially lots of air. And as I said, air and ultrasound does not match. It's only when you see lung pathology that you will start seeing things such as fluid and consolidation. Again, this is another video of showing what normal lung looks like. And one thing that we want to look for is lung sliding. If there is lung sliding, the lung is normal. And we can see, and often people describe lung sliding as little ants walking sort of up and down. And we can see that there. What we do is we put an M mode through the pleura, and there's a sign called the seashore sign to tell us that it's normal. So the sea is above and the sand is normal lung. And that tells us that this is normal lung. A-lines are essentially something called reverberation artifacts. They are reflections of the pleural line, and that is normal. If you see that, it's very reassuring and reassures you that you're seeing normal lung. If you can't see lung sliding, you need to think, what could this be? And the most commonest thing is it a pneumothorax? But there are lots of other causes for this, for example, ARDS, to pneumonectomy, to intubation. And what you will see is there will not be a seashore sign, but something called the barcode sign. As you put M mode through it, it will look like so. B-lines, now these are really important, and we see this in lots of conditions. They mean that there is pathology, especially if you see more than or equal to 3. They obliterate A-lines and implies there is either water within the system, there's fibrosis, there's inflammation. Often you see them at the bases, and they're essentially these bright white lines going from the pleura downwards. What does consolidation look like? Well, these are two examples, and essentially The first picture shows us normal lung at the sides, but there's something in the middle, and that's called the shred sign. It looks like cheese because this is inflamed bronchoaerograms with good going consolidation. Another thing that we describe in lung ultrasound is the tissue sign. So consolidation may well look like liver or spleen, but actually it's consolidation, and often people can mistake that, which is can be dangerous. So that's what consolidation looks like. And here is a scan showing that, and you can see there all this speckling is inflammation and bronchoaerograms within the lung, and this is somebody with severe pneumonia. What about a pleural effusion? So pleural effusion we can pick up very quickly on ultrasound, and the video shows us there's this black white space here which is essentially fluid. The thing that's waving in the background is lung, and on the other side is diaphragm. And it's really important when we're going to do procedures like sticking a needle in or a drain to see how much fluid there is it safe for us to go in, and we can measure the depth. And here's a nice example of what the diaphragm looks like. The diaphragm is a bright white structure which moves up and down with inspiration. You will only see this if there is fluid there. If there's normal lung, it's very rare to see the diaphragm. And you can see here, we can see it because there's a pleural effusion. Remember, the diaphragm underneath it is either the liver or the spleen. And here are something called loculations, and these are patients with TB, and they are pleural fluid, and we can see that the very complex pleural effusion, and if we were to drain this would be quite difficult, and we may need radiological guidance with this. Both these patients had TB. This is an empyema, and as you can see it's a lot of gunk of fluid there, and again it would be very complex for us to pop a drain in there, and we will need some help. So these are the various pathologies that you need to be wary about. But essentially, if there's pathology, you will see it. If there's normal lung, there's not really much to see. So my take-home messages for lung ultrasound, it's actually very simple and easy to learn. As I said, I learnt this by myself, and the more you do, the more you get to recognise pathology. It is more sensitive than chest x-ray and auscultation, and is on a par to CT scanning. It's great in the acutely sick because you can make decisions very quickly, and it prevents them having to be moved to go to CT scan. We know when patients are sick and they move, they deteriorate further. It assists in safe procedures such as pleural taps and chest drains, but more importantly, it will empower you with the knowledge of what is going on with the patient there and then. And patients get their diagnosis at the point of you scanning. Okay, so the next lecture will be on echocardiography and really point of care. So nothing too detailed, but really simple things. What views do you need to take, and how will you do this? What does normal look like? What does abnormal look like? And what are the key questions that you need to ask? And really, we're just asking you to look at LV function. What is the right side doing in the function? Is there pericardial fluid? Is there pleural fluid? And what is the IVC doing? So in a normal echocardiography exam, it should normally take about 40 minutes or so, and another 20 minutes for reporting. But in a POCUS scan, it should really take 5 to 10 minutes. We're doing only a few views, such as the parasternal long axis, short axis, 4-chamber view and subcostal view in a POCUS exam. I always advocate doing a suprasternal view, reason being is that you can pick up other pathologies such as dissection, and we will show you how to do this. This is showing you where you need to put the probes, but the video will explain that in detail. So what probe should you use? And it's the echo probe, the phased array probe, and it's low frequency, but it has high depth, and it's got a small surface area because it can get in between the ribs. Okay, so now we're going to talk through briefly on how to do a focused echo study. Most importantly, you must put the ECG leads on, and the reason being is we need to know where systole and diastole is happening, especially when we're making measurements also of any pericardial fluid. So always try to put some ECG probes on, but obviously in an emergency this cannot happen. Now the first image we're going to get is a parasternal long axis. Using your echo probe with the light facing towards patient's right shoulder, we would put it in the second intercostal space. Sometimes that can be difficult, and what I would recommend is you start from the top and you scroll downwards until you get an image. So you'll scroll downwards until you get the parasternal long axis view, which I'll go through over in the next few slides, but essentially you want to be able to see the aortic valve, the mitral valve, the septum and the posterior wall. And you're looking for, is there any pericardial fluid, what is happening to the LV, and what is happening to the right side as well. Now from this position, you rotate the probe so the light is on the patient's left shoulder, and then you will get the short axis. The short axis is where we're seeing the heart from the top. So you will see the aortic valve, which looks like the Mercedes sign, coming down to the mitral valve, the papillary level and the apex. And what you do is you do a tilting motion like so, and you'll be able to scroll down the heart and look at all these different views. Again, you're looking for what is happening to the LV, what is the right side doing, and any obvious pericardial fluid. The next view that we look for is the four-chamber view, and we feel for the apex beat, and essentially with the light shining towards the patient's left shoulder, we will then place the probe in that area and we will see the four-chamber view. And again, you're looking at what is happening to the left side, what is the right-hand side doing, is there any obvious pericardial fluid. The next image we want to get is a subcostal image, and this is really important because most of our patients are very sick and they're lying in this manner. And the image that we're going to get is a four-chamber view. We hold the probe like so, like a pencil, with a light shining onto the patient's left-hand side, and we place the probe at this sort of angle facing towards the heart and press down firmly, and we then will be patient's four-chamber view. Again, this will tell us if what is happening to the right and left side is any pericardial fluid. Now from this image, we rotate the probe with the light shining towards the patient's head, and we will be able to see the patient's IVC. And that's a really important structure which I'll talk to you about a bit later, because it tells us about what's happening onto the right side, what's happening to the patient's volume. If the patient is awake, you can ask them to sniff, and the IVC will collapse. And that's really important when we're looking for features of pulmonary hypertension. So the next image that I want to share with you, and many people don't teach this, but I think it's very valuable in patients who are in shock or have features of aortic dissection. This is the suprasternal view, and essentially you get the probe with the light shining upwards towards the patient's head, pop it in the suprasternal notch, and essentially by wiggling it side by side, you will be able to visualize the ascending aorta, the aortic root, and the descending aorta. What we want to see is, are there any features of an aortic flap? Is it dilated? Because this could indicate to us that the patient is having an aortic dissection. So let's talk through the images that we captured. The first image is a parasternal long axis. This is where we pop the probe into the second intercostal space with the light shining towards the patient's right shoulder. And this is the image that you will see. So, really important area that you need to know about is the descending aorta, which is a round structure at the bottom of the posterior wall. You have the left ventricle here, and you have the posterior wall, the septum, the mitral valve, and the aortic valve, and this is the right side. The descending aorta is a really important structure because fluid above it is pericardial fluid and fluid beneath it is pleural fluid. You can see also we've got a nice ECG trace. As I mentioned, ECG is really important because it tells us when systole and diastole is occurring, and that is important if the patient has a very poor systolic function. The other thing that I want you to look at is if I put my pointer into the middle of the screen, we can see that the LV, the septum and posterior wall, are coming in towards that pointer. The walls are thickening and it's moving well. That tells us that the LV function is good. And we can see here the aortic valve is nice and thin, and the mitral valve here, I always describe it like clapping hands, is also nice and thin. That is a parasternal long axis view. This is the M mode throughout it. This is a bit more advanced, so we won't talk into detail about this. The next view is a parasternal short axis, and we turn the probe, which now the light faces towards the patient's left shoulder, and this is the view that we will see. We will see the aortic valve, which will be from the top, and we will be able to count how many cusps it has. This is the image you will see. And you can see, you can hardly see the cusps. This is the aortic valve here. And typically we call it the Mercedes sign because there's 3 cusps. But remember, patient may well have 2 cusps and even 4 cusps. But it's good that the aortic valve is nice and thin because that is normal. When it becomes thickened and calcified, it indicates aortic stenosis. As we tilt the probe downwards, we can see this image here. People describe it as a fish's mouth. I describe it like a skipping rope. This is the mitral valve, the anterior and posterior mitral valve leaflet opening and closing. One thing I want you to note is the LV is nice and round. That is a normal LV. It should always be nice and round. As we move down further, this is papillary level, and we can see that also it's nice round structure. And again, you put your pointer in the middle and you can see that the walls are coming in and out and thickening. Now, if you're worried about a heart attack or somebody with a regional wall abnormality, part of that wall may not be coming in, but this is completely normal. And this is towards the apex. The apex is always thick, it's full of muscle. It's also a place where clots live, so this is where we need to look for clots. The next view is a 4-chamber view. Now, we do like to move patients across onto one side because what that does, it moves the lungs out of the way and we get a better image. And this is the image that you will get. And you can see this is the left side and this is the right side. The right side is always 1/3 and the left side is always 2/3. If the right side is the same size as the left side, it is enlarged. That is really important to note. If we put our pointer into the centre of the LV, we can see again the LV walls are thickening, and that is a good sign indicating that the function is normal. It's really important you know about coronary artery territories, because if someone's had an MI, then part of the wall will not move, as I've shown before. The next view is a subcostal view, and most of our patients who are sick, this is the best view to get. You will see a 4-chamber view, but the patient will be lying flat. And here you go, this is the image, and this again is a normal 4-chamber subcostal view. This is the left side, this is the right side. The right side is smaller than the left side, and that is normal. From this view, you can get the IVC. The IVC comes out from the right atrium, and it is a really important structure because it will tell us about volume as well as right-sided pressures. And you can measure that as well. The suprasternal view, again, I feel that's a really important view, and here it's a very difficult view, but it does tell you a lot of information. So this is the ascending aorta, this is their root, these are the common carotids coming off it, and this is the descending aorta. If it's dilated and somebody comes in hypotensive and shocked, we need to think about dissection. So a really key, important view to do in somebody who's in acute shock. These are guidances that come from the British Society of Echocardiography on what is urgent echo and what is non-urgent. And it's interesting that in the 24-hour section, they've put suspected tamponade, suspected effusion. In my view, the list on the left-hand side should all be now. They should all be done within minutes. We all know that in our ALS algorithm, point-of-care ultrasound and echocardiography is part of that, but the reality of it is that this rarely happens. We often call a cardiologist who then can't find a machine, and it takes ages for the machine to be started. It is really important because it addresses the 4 H's and the 4 T's. Has this patient had a PE? Is this patient hypovolemic? Is there tamponade? And often these things we're not addressing when patient is in cardiac arrest or peri-arrest. So that is why it is so important that we learn this skill so that when patients are really sick, we can apply it. So I'm just going to go through a few sort of questions that you'll be asking when you're doing point of care ultrasound. The first question is there pericardial fluid? And this is a normal scan, which I showed you earlier, of a parasternal long axis view. And you can see this here, that round structure, and that is the descending aorta. Remember I said fluid above it is pericardial fluid and fluid beneath it is pleural fluid. This is a scan of a gentleman who's come in short of breath, who was treated for a pulmonary embolism. And you can see here, the heart is bobbing away, surrounded by fluid. And you can see the descending aorta is there because there is so much fluid above it. This is somebody with a large pericardial effusion. And that can be disastrous if it's not treated. Now, is there pleural fluid? Again, this is a normal view of a parasternal long axis, and I said beneath the descending aorta, if there is fluid, it is pleural fluid. And this is an example of that. You can see this is somebody who's short of breath, and there's a whole load of black space here beneath the descending aorta, and this is pleural fluid. This patient, if you look at his LV, it's not doing anything. It's not coming towards my pointer. This patient has severe heart failure, hence he's got a pleural effusion. How is the LV? Now, we're not expecting you to do ejection fractions or make decisions like that. We just need a sort of a view on what you think the LV is doing. Now, this is a parasternal short axis, and you can see that the LV is nice and round and it's coming in towards my pointer. It's thickening and it's really trying to touch that pointer. This is now somebody with dilated cardiomyopathy, and you can see that the wall is very thin, there's hardly any muscle, and it's not coming towards my pointer. And this is what we call a global hypokinesia, and this patient has dilated cardiomyopathy. And we would say that this is severe systolic dysfunction. And this is a 4-chamber view of somebody with the same condition, and you can see that that LV is not doing anything, it is not coming towards my pointer. Back to a normal parasternal long axis view, you can see that the LV is doing very well and coming towards a pointer. Now, I want to demonstrate this particular patient, and this is a patient who is severely hypovolemic and hypotensive. Now, most patients who are in cardiac arrest will not be able to give you an output, but they are hypovolemic. What this shows us is something called kissing lips. The LV is working so hard that actually the lips of the septum and the posterior wall are touching each other. It's working very hard. So this is a sign of hypovolemia. This patient needs more and more fluids. What about the right side, the size and function? Again, this is a gentleman who's coming short of breath, and you can see in the parasternal long axis view, this right heart looks dilated. You've probably already noted as well, there's a small pericardial effusion. And this is a classic picture of somebody with increased right-sided pressures, and you can see that round shape has disappeared and has become a D shape. Remember I said that the left ventricle is always the most powerful and is always round. Here it is getting squashed by the right side, suggesting that the right-sided pressures are taking over the left side. Again, this is what it should normally look like, and you can see the difference from it being perfectly round to it being a D-shaped. Now, this is a 4-chamber view, and you can see here, remember I was saying that if the right side is the same as the left side, it is dilated, and here it is definitely the same size, if not bigger. What is the IVC doing? This is really important because it tells us about volume and right-sided pressures. And here is an IVC, which is essentially normal, and it collapses with inspiration. And whenever you're looking at the IVC, always ask the patient to take a deep breath in. This is somebody with an IVC that's dilated. Anything above 2.5 is increased, and then that can be for lots of reasons, from pulmonary hypertension to an acute pulmonary embolism. This is an example of showing you a normal IVC, and in inspiration it collapses. But you can see this is somebody who's lost lots of blood in a GI bleed, and you can see the IVC is very small and it's kissing lips because it's hypovolemic. So in these patients, we need to give fluid. So take-home messages for point of care echo, really, it is a bit more trickier than lung ultrasound because smaller movements can change images. Remember, we are just answering a few questions. Is there pericardial fluid? Yes, no. What is happening to the right side? And if you're not sure, you just need to ask someone who knows and can interpret your scans. But it is very useful in patients who are hypotensive, in shock, and excluding various pathologies. Okay, for the next sort of 5 to 10 minutes or so, we're going to talk about governance, quality assurance and reporting. It is vital that whenever you scan, there is a backup of somebody reviewing your scans, reviewing your reporting, and we are sharing knowledge and sharing cases. It's not about all the cases that we're picking up. Yes, we picked up effusions to endocarditis and so forth, but just sharing those poor scans, those poor images as well, and thinking, why couldn't I get a scan? So it's about challenging one another. Every department that is scanning, especially point of care, should have a departmental ultrasound lead. What we found is that when colleagues attend courses, they often have an overconfidence in scanning, and there's been quite a few case reports of misuse of ultrasound at the front door. So as I mentioned, there should be a policy in place and there should be regular audit of individuals' work. You should always keep a logbook of all the scans that you're doing as well. It's really important that we keep an eye on the quality of the machines. Do they need replacing? Who is using the machines? Are patients consenting as well? Are we cleaning the machines appropriately and keeping them in a safe place? Where are these recordings going to? And as I said, sharing of those reports and the quality of images with feedback. You are all adult learners, you're responsible for your learning, you need to keep logbooks and continue CPD. There's something called the grandfather clause, and these are people, probably like myself, but I have got the accreditation, that have scanned a lot and necessarily don't need the accreditation but have that experience. When you're reporting, it's really important you answer the question. They need to be clear and concise. What date did you do it? What time? Where was the scan done? What was the quality of the scan? Was it good, fair or poor? Remember, focus scans, you're only answering the question. As I said, is there fluid? Is there RV strain? What is the LV function doing? And this is where you need to use your medical knowledge and think laterally. Remember, you may see somebody with a large IVC and a dilated right heart, but this patient may have COPD and have pulmonary hypertension. So always think laterally and ask a friend. This is something that we do on the acute medical unit. This is our reporting file that we use for each scan that's done. And then we audit this on a regular basis, looking at the quality of scans, number of scans, and the outcome of the scans as well. Thank you for listening.